Before we dive in, a quick note. We are brand new to this and we're still figuring out our equipment. So the audio quality on these first few episodes may not be perfect. We appreciate your patience while we work out the kinks, and we promise we will get better. Hey everyone, and welcome to the Dark Side of Healthcare. Quick note before we get started. If you are watching this on YouTube, this is an audio only podcast. So you're going to be looking at our cover art for the entire episode. We record in audio format and push out to other podcast platforms and YouTube, so everyone can find us wherever they like to listen. So if you are watching this on YouTube, welcome. Grab some headphones, get comfortable, and know that the lack of video is completely intentional. I'm your host, Heather Skousen, and I've spent over 20 years working in healthcare operations and leadership. I hold an MBA with an emphasis in healthcare administration and a bachelor's degree in criminal justice. When we talk about the ways these systems fell, I am not watching from the outside. I have been inside these rooms. This show lives in the intersection of everything I know, and I'm glad that you're here for it. Also with me, let me kind of get Dena ready, Dena is my co-host.
Hello.
Dena, do you want me to give your introduction real quick? It's been a while since we've done introductions, so I'm just kind of touching on it again. Dena is also in the healthcare industry expert with deep clinical and operational knowledge, and she brings an invaluable layer into every case we cover. When we talk about how the why of what goes wrong inside these healthcare facilities, Dena's not guessing. She's been there too. So Dena, welcome back.
Hey, thank you. Today's case is set in a part of the healthcare system that most people interact with regularly without ever thinking about what goes on behind the scenes. Dialysis clinics are everywhere.
They're everywhere.
At times, I don't even think I realized until certain family members
that one was a center that you drive by all the time.
To go, then you were like, oh, that is what that center is. They're very quiet. They're routine looking. And that is part of why this all happened in Lufkin, Texas. And it's disturbing. No one saw it coming, partly because no one was looking. I also want to say really quickly, Heather does a lot of our research for us here. And I don't know what she has against Texas.
I was just going to say the same thing. I mean, Beyonce has a song that she loves Texas. Heather seems to hate Texas.
How many have I done that are in Texas? I'm trying to think. I know that last week was Texas. I know that for sure.
Mm-hmm.
I'm trying to think. Do I talk about guys? If you are from Texas, I love Texas. I have family members who live in Texas. So I am not against Texas, but it's maybe because of how
it's probably just because it probably is.
It is a large area.
Yes.
And so the crime of
is
bigger in Texas.
And then they're all teaching us.
Yeah.
They're learning and
we are getting better because of
Mm-hmm.
Texas.
Yeah.
All right. Okay. Well, thanks for that, Dena.
You bet.
Throw me under the bus. Why don't you? I will try to next week. I will try to find research from a different state.
Okay.
Maybe we'll try like Alaska or something.
Oh, I bet you could find a lot there.
I bet I could. I bet I could.
Or maybe it's hidden so deep you can't.
Maybe. Now challenge accepted. All right. And of course, we have with us Holly, who is a true crime enthusiast, a patient, and a caregiver who has navigated this system firsthand. She is not a healthcare professional, and that is exactly why she belongs in this conversation. If something we say lands differently when you're not inside these systems every day, Holly will tell us. She doesn't know our topic today, and her reactions will be exactly what many of you are probably thinking right now, which is why Holly's here. So welcome.
Thanks for having me.
All right, let's get into it. Imagine you are sitting in a reclining chair 3 days a week.
Not hard
every
to
week.
think about.
Do you already sit in a reclining chair 3 days a week?
No, it's just, it's summer.
That
hot.
is true. Holly's background is she's in education, and so she is enjoying her summer break right now.
That's right.
Yeah.
Good for you.
Sorry, we're making you work on your summer break.
This isn't work. This is enjoyment.
This is enjoyment? Okay. Well, good. I'm glad this is enjoyment. All right. A machine is filtering your blood. Without it, you would die. You are not a hospital patient. You are at a dialysis clinic. a place that feels almost routine by now. Because for you, it's routine. You recognize the nurses, you know the other patients, you trust this place with your life in the most literal sense of that phrase. Now imagine that one of the people responsible for your care picks up a syringe, draws bleach into it, and injects it into your dialysis line.
Okay, wait.
Why?
That's what I was just gonna say. Why? Why would they put?
I
bleach?
have to point this out right now for people who cannot see the people sitting in front of me. I am watching both Dena and Holly on their cell phones, and when I read the syringe full of bleach going into the dialysis line, both heads whipped up. And we're
Why?
like, why?
Well, I was gonna
Why?
look up because Dena said, we drive past these clinics all the time, and so I was looking up dialysis center in our hometown to see if we actually see one.
Research.
But then when you said that, I don't care if there's one in our hometown.
No, you're like, whoa.
Yeah, this is not hypothetical, guys.
Why would they?
You're gonna find out. You're gonna find out. Holly, you just always want to know all the details in the introduction. You gotta wait for it. That is part of the story. Okay. This is what happened at the Dena Dialysis Center in Lufkin, Texas in the spring of 2008. 5 people died. 5 more were seriously injured. And the nurse responsible, Kimberly Clark Saenz, had been hired despite being fired from at least 4 previous healthcare jobs. Now,
here we go again.
Here's the thing. From some of our previous episodes, like our very last episode from last week, the physician resigned so he didn't have to be reported. And with Charles Cullen, he had resigned and been fired. So now we're in another situation where we have a healthcare provider, like a healthcare employee who has been fired.
But does it not count because they're not in a hospital?
You're going to see. You're just going to have to wait for it, Holly. Just wait for it. Okay. Her nursing license showed no record of discipline. No one had checked closely enough to see why she kept leaving. Today, we're going to talk about Kimberly Saenz, but more than that, we are going to talk about the dialysis industry, the regulatory vacuum it operates in, and hiring practices that puts a nurse with a checkered history alone with the most vulnerable patients imaginable, and what, if anything, has changed.
So what strikes me about this case is how ordinary the setting is. Dialysis clinics, they're not thought of as high-risk environments.
Like the way you would think of like an
ICU or an emergency room. Yeah. I mean, these patients are sick. They don't feel well. And the process of going through this for 3 to 4 hours is not fun, but you would still just not think of it as high risk. The patient, they come in, they sit down, they get hooked up. It feels routine. And that routineness can create a kind of institutional complacency. When everything looks the same every day, it becomes harder to see when something has gone badly wrong.
Yeah. So let's give some context to who Kimberly Saenz was, what she did, and how this ended up in a courtroom. Then we're going to spend the rest of the time with the bigger picture. Kimberly Clark Saenz was born in 1973 in Fall River, Massachusetts, and by adulthood had settled in Angelina County, Texas, near.
Do you know what kills me about all
Lufkin.
these?
Yeah.
Their birth dates.
Her age. I know.
Oh, yeah. Just a little older than me.
Yeah.
You two aren't
just a little bit older.
Yeah.
Just a little bit older than, yeah. Exactly.
They're younger.
It's a little bit younger than you. Yes.
Did I say it wrong?
That's okay.
I like to dream.
Why age yourself?
You don't need to.
Right.
You're young at heart.
It
They're
is.
all within a similar range. They're not that much older than we are.
They aren't. Exactly.
Or younger.
She became a licensed vocational nurse. So it's an LVN through Angelina College. An LVN is a step below a registered nurse. So if you don't know like the levels there, and works under an RN or physician supervision. In a dialysis setting, LVNs handle patient care tasks, including administering medications and preparing treatment lines. By the time Saenz had hired at the Dena Dialysis Center in Lufkin in the fall of 2007, she had already been fired from at least 4 healthcare jobs. One of those firings came from Woodland Heights Hospital in Lufkin, where she was accused of stealing Demerol, a powerful narcotic painkiller, and cheating on a drug test.
Well, that's enough right there. Come on.
I know, right? Don't even know why we're even talking about how were you hiring. But the stolen medication was found in her handbag. At the time DaVita hired her, none of those firings had resulted in any action against her nursing license. Her license record was clean, and that is what the background check showed.
How can your license be clean if you've
They
been
Right.
didn't get
fired
reported.
for illegal activity?
Has Holly not been paying attention to
I know,
any
they're
of our
recording.
podcasts?
Well, it's just that question that's not a question, I guess.
Right.
Disbelief.
It's disbelief. It is. It's disbelief. You're like, why have we not learned our lessons from all of this, right? Saenz had been working at DaVita for about 9 months when April 2008 began. And in the first days of that month, patients started dying and collapsing in ways that had no immediate obvious explanation.
Bleach will do that. to
I mean, it
somebody.
will,
Into
right?
your blood
Really?
system.
April 1st, Clara Strange and Thelma Metcalf both went into cardiac arrest during their dialysis sessions. Thelma Metcalf died. Clara Strange did not survive. 2 patients dying on the same day at the same dialysis clinic. The odds of that happening from natural causes were, by one former prosecutor's account, astronomically low. Within the next 3 weeks, more than 30 additional patients were transported by paramedics from the clinic. The Lufkin Fire Department was making run after run to a facility that had previously required emergency services only twice in the prior 15 months.
Huge red flag.
Yeah.
Hey, wait, that was 30 patients
Right,
over
in-
3 weeks.
Yeah.
How
In a small
in
clinic.
a small clinic?
In a
and
small
they go
clinic.
3 times a week, right? Is it what you said is a dialysis treatment? Is it
Oftentimes, yeah.
It's 3 times a week.
Like that patient, but they're running obviously every day.
Yeah, right.
But
there are multiple patients.
Yeah.
But in a small clinic, that is a huge percentage.
it is. It totally is. One fire department official was alarmed enough that he wrote an anonymous letter to state health inspectors asking them to investigate. So he obviously knew, we're coming to this place way too much. That anonymous letter is one of the most important details in this entire case. A frontline responder who kept showing up to the same address, watching people in cardiac distress, and finally said, enough. Someone needs to look at this. It's a reminder that people closest to the ground sometimes see things the institutions above them miss entirely. State health inspectors arrived, and on April 28th, 2008, with inspectors present at the facility, 2 more patients went into distress. And then something happened that broke the case open. 2 other patients who were hooked up to their machines at that moment watched Kimberly Saenz draw a clear liquid from a container that marked bleach.
Wait a minute.
Oh,
the patients
Eve.
The
watched that?
patients watched it
Oh,
Okay.
can you imagine
into 2 syringes and inject them into the dialysis lines of patients Marva Roan and Carolyn Rissinger. So she drew it up, didn't put it into this patient's syringe, but they watched her do it and then go administer it to other patients.
Somebody else.
They told the clinic coordinator what they had seen. The coordinator confronted Saenz. Saenz said that she was using the syringe to measure cleaning solution for an unused machine, a method that was explicitly against DaVita policy. The bucket she was using tested positive for bleach. The syringes tested positive for bleach. Police were called. The clinic was shut down. Saenz was fired the next day.
But what do they do for the patient in that moment?
I know.
I don't even know what you do if you have bleach injected into
Right.
it. I don't mean, what do you do?
Yeah, I don't know.
I mean, I guess if anything, it's good for the hospital to know what
They're treating them for.
and about what they're trying to treat them for. In May of 2008, Saenz was arrested and charged with aggravated assault. A year later, after a deeper investigation, she was indicted on 1 count of capital murder, covering the 5 deaths that occurred in April of 2008.
Okay, so I'm going to back up because a couple of weeks ago we did where the first individual was charged, the CEO was charged with aggravated assault.
Okay, you're talking about with the pharmaceutical,
Right.
But the aggravated assault, that wouldn't have been
That was the
He
pharmacy.
that he was charged with criminal, it was criminal charges, but was it aggravated assault? I don't think it was aggravated assault.
It was assault something, and so it had to be aggravated. Anyway, that's okay. So that was an entity, but this is a nurse that was charged.
This is a nurse.
Okay.
Yeah, so this would
and
be
just a step below.
Right.
yeah,
because-
exactly.
registered.
Yeah, an LVN. So this is basically your professional,
your provider.
your providers, right? So last week we talked about Dr. Death. So
Right.
right. So Dunch.
Yeah.
And then also colon. It would be like that comparison. Right?
Yeah.
So, okay. Let's see. Where did I get to, Holly?
So
she was indicted on one count of capital murder.
Okay. Covering the 5 deaths that occurred in April 2008 and 5 additional accounts of aggravated assault. The capital murder charge meant she could face the death penalty. The trial didn't begin until March of 2012, nearly 4 years after the crimes. 4 weeks of testimony, 14 hours of jury deliberation. The defense argued that Saenz was being scapegoated for broader systemic failures at the clinic, including problems with water purification
yes,
systems.
that's what did it.
Yeah.
Do we know why it took 4 years to be?
I think if you think about how slow some
cases are really
like
fast
sometimes they can drag things out. I mean, it depends. Like sometimes people will have a change in representation and they will do.
I just wondered if it was delay tactics or if it was the states
or them just trying to build up enough evidence before they brought it before.
The prosecution pointed to the eyewitness accounts, the positive bleach tests, the computer searches on Saenz' home computer for bleach poisoning in blood. So it's obviously
what I'm searching for as I'm sitting here listening. And yes, I'm searching things. I got to be careful what I'm searching.
We have joked about that before. As if somebody ever came and had to confiscate our computers because we are also true crime enthusiasts. So they might find some questionable searches on our computer.
No, we're just doing podcasts.
The positive bleach test, the computer searches on our computer. The search is conducted on the morning of April 1st before she went to work on the day that 2 patients died. So the day that 2 patients died, she searched blood poisoning with bleach. The forensics evidence was compelling. Oh, Dena, help me.
Chlorothiazine.
Okay. Dena's she's my researcher on how to say some things. The chemical marker produced when bleach reacts with proteins in the blood was detected in the blood of the victims. That is not something that occurs naturally. It requires exposure to hypochlorite. The science pointed directly at the bleach poisoning. The jury found Kimberly Clark Saenz guilty of capital murder and 3 counts of aggravated assault. On April 2nd, 2012, almost 4 years to the day from the first death, she was sentenced to life in prison without the possibility of parole. She also received 2 concurrent 20-year sentences for the assault convictions. She is currently incarcerated in the Texas Department of Criminal Justice. She has maintained that she was innocent. And that is where most coverage of this story ends. But for us, it's where the real work begins. Because the question Kimberly Saenz forces us to ask is not only why she did this, a question we may never fully understand because we might not get the answers to that, but how every system that was supposed to stand between her and her patients failed to do so.
Hello. Let's start with the hiring. How does someone with Kimberly Saenz history get a nursing job at a dialysis clinic serving the most medically fragile patients in the community? The answer lies in how background checks work in healthcare, and more specifically in the gap between what employers are allowed to check and what the nursing license system is designed to capture. When a healthcare employer like DaVita runs a background check on a job applicant, they are typically looking at the criminal history. What they are not looking at, cannot easily look at, is the reason a nurse left every previous job. And here is where the structure of nursing licensure creates a clinical blind spot. The Texas Board of Nursing licenses nurses. It investigates complaints filed against the nurse. It can suspend or revoke licenses, but complaints have to be filed and investigated before any action appears on a license record. If a nurse is fired, even fired for a suspected drug theft, even fired multiple times, and the employer does not file a formal complaint with the state board, that history is invisible to the next employer.
It just seems like that should be a requirement.
It should just have to be. And I have to wonder, does it come down to laziness a little bit?
Sometimes. I mean, there's a lot. I mean, we've already said healthcare is grossly understaffed.
Did you write them up? Did you give them? I mean, how many things do you have to fill out? It should just be, once again, everybody's trying to protect this or that you can't just go negatively against the innocent.
Right.
But Yeah.
But when you had a fireable offense,
Right.
you already know that it's documented.
Well, and here's the thing I think is interesting is, so Heather already mentioned I'm in the educational system. We have to report everything because we're dealing with minors.
Mm-hmm.
Exactly.
You would think that somebody who's dealing with a life should be held to a similar standard of reporting when there's a crime.
You would think.
Or when there's reasonable reason for firing.
Yeah, you would think. Employers often fear litigation. So this is kind of some of the reasons why. If you file a complaint that is later not substantiated, the nurse can come after you. And in a tight labor market for healthcare workers, some employers also make a quiet calculation. This nurse is someone else's problem now. Passing the lemon, the trash. They resign, they move on, we avoid the paperwork. As we talked about in the Charles Cullen case, this is called moving the trash. Okay.
There is also peer review privilege dynamics similar to what we've discussed in other episodes. Internal investigation findings at a healthcare facility, what the committee found, what the evidence showed, why the person was terminated, are often legally protected from disclosure, which means a new employer calling for a reference gets the same carefully neutral response. You get the date of employment, their eligibility for rehire, nothing more, which we kind of talked about. Everyone's protecting themselves. In Saenz' case, Woodland Heights Hospital had physical evidence that she had stolen controlled substance. The Demerol was in her bag. She failed a drug test, and yet according to what came out at trial, none of that had made it into her nursing license record. When DaVita ran their check, the license was clean. And so once again, I have to ask,
was it laziness?
Because how could she come back on you? You have physical proof of that.
She failed a drug test.
So so you put that in the record. How can she come back?
She failed a drug test and she was found with it in her purse.
Right. I mean, if she had wanted to fight that, she could have, but it can go on her license until that point.
I think she could probably fight the search of her purse, possibly.
Right.
But not the failed drug test. Because when you sign on to work for a healthcare organization, you actually agree that they can test you anytime.
Yeah. So why it was there. This is a problem that goes well beyond Kimberly Saenz. Studies of nursing discipline systems have repeatedly found that a significant proportion of nurses who are fired from healthcare jobs for serious reasons are never reported to the state boards. The estimate varies, but the pattern is consistent. Underreporting of nursing misconduct is widespread and structural. The board only knows what it is told.
And there is another dimension here specific to the dialysis setting. DaVita is not just a clinic. It's a massive corporation. At the time of the Lufkin case, DaVita operated or provided services for more than 1,800 dialysis facilities across the country, serving some 142,000 patients. That scale creates its own pressures. Staffing dialysis clinics is difficult. These are long shifts, demanding work, working with patients who are chronically ill and often emotionally exhausting to care for. The pool of qualified applicants is not unlimited. I want to be clear, this is not an excuse for what happened, but it is a structural reality that when you are running dozens or hundreds of clinics and you need to fill positions, the scrutiny applied to any individual hire may be less rigorous than it would be if you were in a smaller organization where every hire is more visible. Scales create blind spots.
In a functioning system, Woodland Heights Hospital files a complaint with the Texas Board of Nursing the day they find Demerol in the nurse's bag. The board investigates, takes action, and that action appears on her license record. The next employer queries the license and sees it. The hire does not happen, or it happens with full knowledge of the prior conduct and the specific conditions attached. That is how the system is designed to work. It did not work that way here because the very first step, the report, never happened. I do want to be careful because we do talk about laziness and things, but I do know there's understaffing at times and certain things like that, and we start getting behind on certain things. But
and it goes back to that not every provider is like this either.
Exactly.
This is what we're talking about in this podcast typically is a very small percentage.
Yeah, we talk about the extremes, but I do want to be clear that the systems still have problems.
Yeah.
And so even though we're talking about extreme cases,
Sure.
we still have systemic problems or systemic failures that need to be better.
Well, and it makes you wonder too, these are the ones that get found out. These are the ones that are
Right.
identified. How many other failures
do we not know about that could end up affecting us or a loved one?
Yeah.
At the end of the day, yes, the systems need to be fixed, but we also hope that people are learning that, there's so many things they need to check into themselves and protect themselves.
That's also why we do this, right? Is to educate everybody. We all play a role and have a responsibility in our healthcare.
Exactly.
Yeah. Now let's zoom out from the individual hire to the industry that hire happened in, because dialysis clinics occupy a generally unusual regulatory space in American healthcare. And that space created conditions that made what happened in Lufkin possible. Dialysis is almost unique among medical treatments in that it is not primarily delivered in hospitals. It happens at freestanding outpatient clinics, most of which are owned by two large for-profit corporations, DaVita and Fresenius. Together, those two companies control roughly 75% of the dialysis market in the United States. And the regulatory oversight of those clinics has historically been weak. Dialysis facilities are certified by the Centers of Medicare and Medicaid Services, or CMS, under the set of conditions called the ESRD conditions of coverage. ESRD stands for the end-stage renal disease. These are federal standards that clinics must meet to receive Medicare reimbursement, which is the financial lifeblood of the dialysis industry. But meeting those standards is verified through inspections, and here is where the numbers get alarming. Reporting by investigative journalists and government oversight bodies has found that dialysis clinics are inspected on average far less frequently than any other healthcare facilities. Nursing homes are typically inspected annually. Hospitals receive regular surveys. Dialysis clinics, depending on the state and the year, might go years between inspections. In some states, restaurants are inspected more frequently than a dialysis center. And
which I'm grateful that my restaurants are
Yes.
inspected, but I'd also like my healthcare.
I would like my
providers
healthcare, my facilities to be inspected too. And dialysis patients are not choosing to go there the way you choose to go to a restaurant. They go there because they will die if they don't.
Well, and I did do the search to see if there are any in our hometown. And they listed as two, but they're both located in the exact same facility. So I'm figuring it's just
it's very limited, right. Your choices. Like when we say to protect yourself and to check things out, but so you're limited.
One choice
here.
Uh-huh. And if you need
and these patients are sick.
Yeah,
it's not like they're going to be driving
an
hundreds of exactly.
Yeah.
They are captive, medically dependent population with very limited ability to walk away, very limited ability to comparison shop, and as Lufkin case showed, very limited ability to know when something is wrong until people start dying.
The infrequency of inspections is compounded by the concentration of market power. When two companies control three-quarters of the industry, they have enormous lobbying resources to resist additional regulation. The dialysis industry has historically been effective at fighting off stricter oversight requirements at both the state and the federal level. A 2008 California bill that would have mandated annual inspections died without a single hearing, partly due to industry opposition and cost concerns. There's also a critical staffing dynamic inside dialysis clinics that contributed to the conditions in Lufkin. I've heard that before.
Yeah.
It's really hard to get help. Dialysis technicians, the staff members who actually set up the machines, draw blood, and monitor patients during treatment, have historically had inconsistent certification requirements across states. Some states require formal certification for dialysis technicians. Others do not. This means that in some facilities, the person hooking you up to the machine that filters your blood has completed, and we're talking filters your blood, it's coming out, going back in, has completed a few weeks of on-the-job training and no more.
Yeah. Okay. So now let's talk about bleach. Okay.
What I know about it is I use it to clean up messes or make my whites whiter.
Okay. Yep. And you used one of the terms, clean, right?
Yes.
And bleach critically is a routine part of a dialysis clinic operation. It is used to disinfect the lines and machines between patients.
Not when they're hooked up to a patient.
No.
Correct.
I mean, was she just taking it out the middleman and shortcutting it?
She was trying to do her job.
Multitask?
Yeah.
No.
To get it clean and
I'm going to clean
Yeah.
while it's still disconnected.
Right.
It is stored in the clinic. It is handled by staff regularly. In a properly functioning clinic, there are protocols for how bleach is handled, stored, and used. But when the substance you are using to kill one patient is also the substance being used to clean the machines, and when oversight is thin and staffing is stretched, the opportunity for harm, whether it's deliberate or accidental, is heightened. There's also
I have a hard time believing this was accidental.
well, especially since it happened so many times.
So many times.
Yep.
Yeah.
Yep. There's also the question of how the clinic responded when the deaths began. After 2 patients died on April 1st, DaVita sent a clinical coordinator from outside the facility to investigate. She made changes to shift assignments. She tried to separate out certain nursing duties, but she did not close the clinic. Patients kept coming in for treatment. More patients suffered cardiac arrest. The death count kept rising, and no one in the critical weeks between April 1st and April 28th identified and removed the threat. I want to be fair here and note that identifying an active predator in your workforce is not it's not easy, it's difficult. These events can look like a statistical anomaly before they reveal their pattern, but the speed and severity, that's where we're talking about, is that you pointed out 3 weeks, and it was a fire department employee who had to say, this is not normal. This is what was happening in Lufkin when extraordinary and the response in hindsight was not adequate with the emergency.
Like Heather mentioned, the fire department paramedics saw it. They were the ones going into that address again and again, loading patients into ambulances, watching the numbers mount. And that would be so shocking. A place you hardly went to, and then suddenly you're going. You would think managers would.
Yeah, you would think, what is
clinic.
administration? Yeah.
And thankfully, one of them cared enough to write an anonymous letter. The institutions, the clinic, the company, the regulators moved more slowly than the person on the front line who had no formal authority at all.
There is a structural tension at the heart of the American dialysis system that Saenz case puts into sharp relief. Dialysis is kept alive almost entirely by Medicare funding. In 1972, Congress passed legislation extending Medicare coverage to virtually all Americans with end-stage renal disease, regardless of their age. So you do not have to be 65.
It's a great benefit.
It is.
Because it's got to be an expensive treatment.
Exactly.
Mhm.
Yep, it is. It was a landmark humanitarian decision. The effect was that dialysis became almost immediately one of the most reliable reimbursed medical procedures in the country. And where there is reliable, large-scale government reimbursement, private capital follows.
We've already talked about that.
That, right? DaVita and Fresenius are publicly traded companies. They have shareholders. They have quarterly earning calls. They operate on margins. The business model for for-profit dialysis is built on treating as many patients as efficiently as possible. That creates an incentive structure that is not always aligned with the patient's best interest. Studies have consistently found higher mortality rates at for-profit dialysis facilities compared to non-for-profit ones. In 2010, study found that patients treated at for-profit chains had worse outcomes. Another study showed patients at nonprofits spent fewer days hospitalized. The data is not unclear. The profit motive, when applied to a medically captive population in a weakly regulated environment, produces worse outcomes.
The differences between a nonprofit and a for-profit show up most clearly in staffing. For-profit dialysis chains have historically resisted staffing ratio requirements, arguing they are unnecessary and costly. Unions representing dialysis workers and nurses organizations have pushed back, arguing that understaffing leads to medical errors, longer treatment times, inadequate monitoring, and, critically, an environment where a single staff member can harm patients before anyone notices because no one is watching closely enough. In the Lufkin case, the clinic had roughly 30 staff members total. Patients are in the chairs for 3 to 4 hours at a time, several days a week. The ratio of staff to patients and the arrangements of duties meant that one nurse could be moving between patients, preparing lines, handling medications without continuous oversight. That is not unique to DaVita or to Lufkin.
Yeah, to Lufkin, Texas.
It is the operating model of the most American outpatient dialysis clinics.
See, I'm not picking on Texas.
No.
There is also a patient advocacy dimension worth naming. Dialysis patients are among the least visible and least politically powerful patients in the American healthcare system. They are often elderly. They are often poor. They are often people of color. African Americans develop kidney failure at rates roughly 3 times higher than white Americans due to a combination of higher rates of hypertension, diabetes, and limited access to preventative care. They come to these clinics because there are no other options. They are not in a position to complain loudly and risk the care they depend on to stay alive. That vulnerability is structural, not incidental, and it matters to how we think about accountability. A system that primarily serves people who are not politically vocal, who are not economically powerful, who have no alternatives, that system faces much less external pressure to perform. The people who could demand better are the least equipped to do so. One advocate I came across in researching this case put it simply: dialysis clinics often aren't on the radar. Legislators pick their priorities by who raises the most hell. Dialysis patients don't raise hell. They show up 3 days a week and hope the system works.
Oh. Let's talk about what has actually changed since the Lufkin case, because we owe it to the patients who died and the families left behind to be honest about whether the system learned anything. The honest answer is some things have changed and not enough has. On the nursing licensure side, there have been meaningful improvements in what is known as the nurses system. Let's talk about what has actually changed since the Lufkin case, because we owe it to the patients who died and the families left behind to be honest about whether the system learned anything. The honest answer is some things have changed and not enough has. On the nursing licensure side, there have been meaningful improvements in what is known as the nurses system, a national database maintained by the National Council of State Boards of Nursing that allows employers to verify nurse licenses and look up disciplinary actions. Most states now participate. The database has become more comprehensive and more accessible to employers.
But the database only reflects what states report, and states only report what boards investigate, and boards only investigate what is filed with them. The pipeline still depends on employers doing what Woodland Heights Hospital did not do, which is file a complaint. The link in the chain remains voluntary in most contexts, and underreporting remains a documented problem.
There has also been movement on the federal level regarding dialysis facility oversight. CMS updated the ESRD conditions for coverage in 2008, the same year as the Lufkin case, with revisions meant to strengthen patient safety requirements, infection control, and staff training standards. These were meaningful updates, but the inspection frequency issue was not resolved. Dialysis clinics are still inspected far less frequently than other healthcare facilities in most states.
California has been the most active state on this front. Legislation requiring more frequent inspections and minimum staffing ratios for dialysis clinics has been repeatedly introduced and repeatedly fought by the industry. A 2018 ballot initiative that would have capped dialysis company profits and required reinvestment in patient care was defeated after DaVita and Fresenius spent nearly $111 million to oppose it. One of the most expensive campaign finance battles in California history. The measure failed. $111 million to defeat a patient safety measure. Let that number sit with you for a moment.
Yeah.
When it should just be a given.
Right.
Right. Some of the arguments the industry made against those measures were not entirely without merit. Strict staffing ratios can sometimes have unintended consequences, and dialysis is a specialized field where matching ratios to the hospital model isn't always straightforward. But spending $111 million to block a vote tells you something about the priorities at work.
Yeah, that's the difference for profit, right? On the bleach handling side specifically, DaVita revised its protocols following the Lefkin case. Syringes are no longer to be used to measure bleach solutions. Access to bleach and other cleaning chemicals are more restricted during patient treatment hours. These are good changes. They are also the kinds of changes that required 5 people to die before those changes happened. So, where does that leave us? What does this case tell us still needs to change?
First, mandatory reporting and nursing misconduct. Right now, in most states, when a healthcare employer fires a nurse for patient safety reasons, reporting to the state board is encouraged, but not always legally required, which you kind of said earlier. It should just be legal. You just have to do it. That needs to change. When you terminate a licensed professional for conduct that could endanger patients, the licensing body should know.
Well, and I'm going to, like in education in my state, when an educator loses their license, that's gone through a professional ethics board, and it is public knowledge.
Yeah.
So like it is out there that it could be that Holly lost her license.
Yeah.
And anybody could look it up.
And all we're asking is
know.
to just make it so that this is visible to healthcare, like the healthcare facilities.
Just to someone who's looking to hire this nurse, not where you could Google it.
Yeah, and I'm not saying the educators shouldn't have that requirement. I'm saying maybe
Mhm.
people who have
Let's raise the level exactly for what this industry should be doing. Second, inspection frequency. Dialysis clinics that serve medically dependent patients multiple times a week should not be inspected less frequently than restaurants.
Exactly.
CMS has the authority to increase inspection requirements. Congress can direct additional resources to make that happen. The political will is the obstacle, not the legal framework.
And once again, let's not decrease the expectation in restaurants. Let's
increase this other. Right.
Exactly.
Third, staffing ratios and patient-to-nurse standards for outpatient dialysis need to be federally defined and enforced, not left to individual company policy. DaVita sets its own staffing standards. Fresenius sets its own. In a market where 2 companies own 3/4 of the industry, self-regulation is not adequate.
Yeah. Fourth, and this one does not have an easy fix, the power imbalance between dialysis patients and the companies that serve them. These patients are a captive market. They cannot easily change providers even if they wanted to. Their geographic options are often limited. Like Holly said, where we live, there's only one place that the patients in our area can go. Dialysis facilities are not evenly distributed. They are too sick and too exhausted to be advocates. The people who have the loudest voices in the rooms where decisions get made are the corporations and their lobbyists. That imbalance needs active countermeasures. Patient advocates with real authority, complaint processes that are actually accessible, and public reporting on patient outcomes by facility that patients and their families can actually access, and understand. You can look up a dialysis facility's CMS certification status and inspection history through the Medicare Care Compare tool online. It rates dialysis facilities on a 5-star scale and includes quality measures. It is not perfect, but it is a starting point. You can ask your nephrologist about outcome data. You can ask the facility directly about their staffing ratios and how they handle patient complaints. You have the right to file a complaint with your state health department or CMS directly if you believe a facility is not meeting standards. None of this is easy, as it should be, but it is available. And for healthcare professionals listening, if you see something in your facility that worries you about patient safety, report it. That anonymous letter from a fire department official saved lives in Lufkin. Not every intervention has to come from inside the building. If the institution is not responding, the state health department has a tip line. CMS has complaint mechanisms. Journalists cover this. And as this case shows, one person speaking up can change everything. I want to say something about the 5 people who died in Lufkin. Clara Strange, Thelma Metcalf, Garland Kelly, Cora Bryant, Opal Few. These were people who showed up to a clinic 3 days a week because they had no choice. They trusted the facility with their lives. They died because one person chose to harm them and because every system that should have prevented that person from being in that room had already failed. We say their names because they deserve to be remembered as people, not just as a case study. Kimberly Clark Saenz is serving a life sentence without parole. The families of her... Sorry, I got a little crazy with my script here. It went kind of a little crazy. The families of her victims deserve justice, and by the law's standard, they received it. But justice for the individual does not repair the system that put her in that room. That work is still unfinished. If you are a dialysis patient or a family member of one, look up your facility on Medicare Care Compare. Ask questions. File a complaint if something doesn't feel right. You are not powerless, even if the system makes you feel that way. If you work in a dialysis clinic or any healthcare facility for that matter, the anonymous letter from a Lufkin Fire official is a model. If you see a pattern that worries you, say it. Say something. It does not have to go through your chain of command if that chain isn't responding. Holly, any last questions or comments?
Well, you just said what I was thinking. We tell students this all the time. If you see something, say something. Whether that's a student who's at risk of harming themselves or bullying issues or something that seems unsafe. If you see something, say something. And I think that is a practice that goes well beyond school systems. And that fire paramedic was willing to say something. There are ways of anonymously reporting some of these concerns. And if you don't feel like you can say it with your name behind it, then say it anonymously so that it can be brought to light somewhere.
Exactly.
And if nobody does anything in that first saying it, keep saying it.
Keep saying
it. Find another place to say it.
Yes, just like in our...
Do the right thing.
Do the right thing. Just like in our last one, it talks about media and things, trying to get it forward, put it out there. If it's real, if it's true, if you saw it, get it out there, get an investigation going. And I'd just like to say one last thing.
Yeah.
We don't do this, once again, to make you feel powerless. We know that at times you're sick, you're tired, things are going on, but you can still have a voice and you can still get things out there. You still have the power to move it forward.
And we want to be here for you for that voice. That's why we like to do this podcast, is to provide some education and resources to allow you to know how to use that voice. So thank you for that. Thank you for listening to The Dark Side of Healthcare. All sources are linked in the show notes. If this episode moved you, share it, leave a review, and we'll see you next time, because there is always more.
Bye.
Bye-bye.
Bye-bye. Thank you for listening to The Dark Side of Healthcare, presented by Behind the Business of Healthcare.